Hi everyone, welcome to Bay State Forum. I'm your host, Barbara Anthony. Bay State Forum is a public affairs program coming to you from Cambridge Community Television. Our last show focused on changes to the Affordable Care Act, known as Obamacare, that were taking shape among House Republicans in Washington. After that show was aired, Congress passed the American Health Care Act, which would repeal most core provisions of Obamacare. The fate of Obamacare and the American Health Care Act are yet to be decided when the U.S. Senate takes up the issue. Today's show focuses on what Massachusetts should do now in the face of so much uncertainty. Remember that Obamacare was modeled after RomneyCare, which was adopted by Massachusetts back in 2006 to move us toward universal health care for all. But now, what happens if there's no longer a federal requirement that all people have to buy insurance? Or if people with pre-existing conditions can be charged more for their insurance or even denied coverage or priced out of the market? Very importantly, what happens if Massachusetts loses billions of dollars if there is a pullback in Medicaid dollars from the federal government? And last but not least, what can Massachusetts do to control its highest in the nation healthcare costs? So here with me today to talk about these important issues are two people with great expertise in both Massachusetts and national healthcare policy. John Hurst is the longtime president of the Retailers Association of Massachusetts, known as RAM. RAM is a statewide organization of 3,200 retailers and restaurants all over the state. John has been a longtime advocate for lowering healthcare costs and improving quality for the small business market. Josh Archambault is a senior fellow in healthcare and a consultant at the Pioneer Institute, an independent public policy think tank located in Boston. Josh has worked at the Heritage Foundation and has served in high-level positions in the Massachusetts legislature and executive branches. Josh is a frequent advocate for market-based solutions to our healthcare problems. And in the interest of full disclosure, I'm also a senior fellow and consultant in healthcare at the Pioneer Institute. And today, in addition to being your moderator, I will also participate in the conversation. So welcome, John, welcome, Josh. It's a pleasure to have you, and let's get started.
Thank you.
So, there's so much to talk about, so I try to organize this in a way that makes sense to anybody listening to this conversation, viewing us. I want to talk about the commercial market, I want to talk about Medicaid and some other things. So let's start with the commercial market. And by that, now you guys jump in if I'm wrong here, what I mean is by the commercial market is the commercial insurance market. People who buy their insurance from an insurance company. So individuals like consultants, like maybe Josh or I, or people who are small business employees like yourself, John. It excludes it excludes people who work for large employers and who buy their health care from the large employer, because the large employer self-funds it and doesn't buy it from an insurance company. So is that pretty much a good explanation of it?
That's correct, Barbara. The commercial marketplace here in Massachusetts today actually it's shrinking, and it has been shrinking for the last decade. About 40% of the marketplace here in Massachusetts, commercial marketplace, is actually what you would call fully insured, where you're part of the state risk pool, the merged marketplace of individuals and small businesses, or the large group marketplace where you're buying commercial coverage from the insurer. 60% of the marketplace now is self-insured, where your large employers, whether you be a private employer or a government employer, you're self-insuring, using Insure just to really process your claims, and you are insuring your own risk pool. You aren't really cross-subsidizing anybody else, but you're paying your own claims for your own people.
Right. And insurance companies just administer that.
That's right.
People think they're
I was just going to make that point, exact point,
Yeah.
Barbara, that employees actually probably have no idea.
Right.
They have a Blue Cross Blue Shield, they have a Harvard Pilgrim, they have a Tufts insurance card, and they don't know this distinction, but it is an important one when it comes to whether the state or the federal government regulates something. But that's what's happening behind the scenes.
Right.
So much of what we talk about, frankly, are risk pools and who controls that risk pool.
Right. So if you work for a Comcast or Verizon or Bank of America or GE, or I'm not not giving free advertising here to people, but just to give folks an example of some large companies, and large supermarkets can be self-insured, correct? So even
the state of Massachusetts,
absolutely, the Group Insurance Commission. So that's what we want to talk about. Now, one of the things that's been going on, and I know we're all aware of it, especially you, John, is that the commercial market, the small group market, which is comprised of employees of small businesses and individuals, have seen some double-digit increases, which is not unusual, unfortunately. So, what's going on here? What accounts for these double-digit 20? I know Pioneer. I guess I can say this. We got a double-digit increase in the 20s.
Well, look, Barbara, I mean, this is a big problem. We're all concerned about how big the pie is, the pie for all of us, the cost of healthcare, and a lot of that is a function of increased cost for our provider community that they're passing on to consumers and taxpayers. But equally important is how that pie is cut up, it's divided. And from my standpoint, it's unfairly divided, particularly if you happen to work for a small business. You're paying really much more than what your actual fair share of that pie is.
Why is that? Can you explain that?
You're frankly cross-subsidizing others, where if you work for a big employer, you're just only paying your share of the premiums for the people within your own risk pool, that under that umbrella of that employer. You know, in Massachusetts, if you work for a small business, you're cross-subsidizing individuals.
How many people are in this small group market?
About 800,000.
Okay.
We're the only state that we put small businesses and their employees together with individuals. No other state did that, and that probably was a mistake for small businesses.
Okay, so individuals could be a really independent contractor, or an artist, or a musician, or somebody who's just not connected to an employer in the market, but they are lumped for insurance purposes with all these employees of small businesses.
And
so why is that a bad deal? Why is that a bad deal for small businesses?
Well,
are you saying that those people are more sick, or that
some of them may be, but they may pop in and out of the marketplace more, when they want it. Even, maybe the penalties for them to buy insurance or not buy insurance is not all that high. And if you work for a large employer, you try to instill a philosophy with your employees and their families that you want them to be healthy. You want wellness activities. You want them to be good consumers, to know where to shop for the right types of services at the right prices, at the right quality levels. And because you do that at a large employer, your costs are going to be lower. You're also not going to be paying for a whole lot of state mandates that the small employer has to. So for a variety of reasons, these small businesses, on an apples-to-apples basis, they're paying a lot more for their coverage than if their employee worked for a big competitor.
Okay. So we'll come back to you on this, because I know you've got some answers. But Josh, what are some of the answers to help the small business employee reduce premiums? Sure,
and let me say that the issue of why the premiums are going up, there's many layers to this, and within that is possibilities for the solution to how you get out of this. So John mentioned mandated benefits. So these are things that actually the legislature here in Massachusetts passes and only applies to individual and small business plans. So it could be anything from autism coverage to hair transplants to a number. I think we're in the high 40s to 50s or so. So that's one answer, is that the legislature could make a policy decision to say we are not going to have as many mandates, and that would reduce insurance premiums. That's one. The other thing is that the Affordable Care Act did inject a lot of uncertainty into the insurance market from the perspective of there are these large sums of money being transferred between insurance companies over the last few years. And in practice, what that has meant here in the Bay State is Blue Cross Blue Shield has received tens of millions of dollars.
This is to compensate allegedly to compensate those insurance companies who have a higher percentage of higher risk, sicker patients.
Correct.
From those insurance companies who don't have.
Correct.
So the ones who don't have give money to the ones that do have higher risk patients.
Correct. That's the theory behind the formula. There's been a lot of complaints.
It's called a risk adjustment factor.
Correct. Risk adjustment payments. The challenge here is that
and that hurts small business.
It can if they're on one of the insurers that's having to pay one of these large sum payments.
Right.
And to make up that difference, the very next year that insurer has to increase their premiums to try to make up for the losses that they had related to that.
Right.
So there's, that's a federal question come forward. I think John is starting to hint at something where large companies have the resources. They have a HR department to think about different incentive programs. They're seeing the actual numbers of what they're paying to a different hospital, and they can encourage employees to go to perhaps a community hospital or a standalone clinic, which is a third of the price. Right. They reap the benefit. Unfortunately, small businesses and individuals, they never see that information. They're just accepting what the insurance company has negotiated behind closed doors, and they don't even know where the good deals are. So I think one of the possible solutions is a cultural change here in the state, and something I know you're extremely passionate about, Barbara, is transparency. And for folks in small business in particular who have high deductibles, they have to pay more money out before their insurance kicks in. We have to give them the tools to be able to know where these lower cost options are.
But how would that help? They're part of a group of 800,000.
Correct.
I mean, so, John's company could save $200,000, $300,000 a year by incenting employees to go, to lower cost providers, but that benefits the whole pool. It doesn't benefit XYZ company.
And it's a hard sell when you're part of this huge risk pool. I think we need to get to a place. Small groups, cooperative groups. We set down the path in Massachusetts to do nonprofit small business cooperatives. Unfortunately, the ACA got in the way of that and effectively neutered them, getting rid of. We went from 13 state rating factors in Massachusetts down to only 4. That's not good. I mean, to have fairer rates, you want more rating factors, not less. And
rating factors are like discounts for certain things.
It's ways of setting fair insurance rates, right? Okay. And I think you need to incent people to use transparency and to do wellness programs. I mean, if you do these things, your claims should drop. If your claims should drop, your premium should drop.
So we need to figure out a way so that small business has an incentive to do what Josh is talking about.
It's got to result in lower premiums.
So absolutely, and you're right. I am passionate about transparency, and we're not there yet, but we're fighting the good fight. What about uncoupling or demerging the small group market? Separating small businesses from individuals.
I think it
would that help?
I think it would help. I think it's a tough political push at this point. But I think it's something that we should talk about here in Massachusetts. We also need to talk about ways to, get rid of, as Josh pointed, some of these mandates. Make them mandates to offer, perhaps. I think, for instance, the prescription drug, and we keep on adding on. We've added 19 new mandates since RomneyCare passed 11 years ago. That's a lot of mandates that big businesses don't have to cover, but small ones do. Some of these things, it ought to be like your auto insurance or homeowner's insurance. Maybe the consumer decides what coverages they want. Do they really need the latest new big pharma drug, when an old generic is just fine? I think when we've mandated all these prescription drug coverages, what we did is we took away choices and power from the consumer. We really put the power, economic power, into the hands of big pharma to not only have increased utilization, which is good for them, higher traffic, but also uncontrolled price increases. We need to find a way to empower the consumer again.
I mean, but in Massachusetts, you have to prescribe a generic unless there's some reason, and most insurance companies are pretty. I mean, they don't roll over on that.
But even generics are starting to get out of control.
Yes, we'll do a show on drug pricing soon. But let me just ask you a quick question. We're going to go on to another subject. If you did demerge the market, what would that mean for individuals? Could we see their rates go up, Josh?
Yeah, possibly. The Division of Insurance has actually done some work on this, and this is kind of the weedy area of healthcare but it has real practical implications. Now, the theory behind merging the two markets, just for viewers, was the concern was individuals were paying a lot more for insurance. They were a little bit sicker. That was due to a number of regulations that had been passed in the past. Now, you could get rid of those regulations. That's a discussion to have. But the theory was you need to get more people in. And so if you drop premiums, more individuals would come in. Now, if we believe that Massachusetts' coverage rate is almost 98% or so, then that would negate the reason for the original merge, that people aren't in anymore. And so if you were to separate the market, you would see individuals pay a little bit more, but Perhaps then you decide a way to help individuals who are lower income in that situation with an additional subsidy of some sort. That's one possibility, instead of forcing everybody to pay more by forcing them together.
Okay, but the underlying theory would be that the small business pool in and of itself, it would be a healthier pool and would receive lower premiums than individuals. And Josh is saying, so if there are those who can't afford them, then we may be able to provide some kind of subsidy coverage.
Absolutely. I think what we've done, unfortunately, through bad public policy, we're starting to incent even small businesses to go self-insured on their own, create their own risk pools. I mean, it used to be that it was just employers of 200 or more. Now it's I've heard of some down at 25.
I want to talk about that, because I do want to ask you what happens if nothing changes, because it is a serious issue. So and you're right, the politics of this are very complicated, and there are intense feelings, obviously, on both sides, as we know. So let's move to another subject now, community rating and guaranteed issue. And guaranteed issue, and again, correct me if I'm wrong here, is simple. And this is we've had guaranteed issue in Massachusetts since the 90s, and it just means that insurers have to sell to you regardless of your health status. So if I come in, I've had chronic asthma or diabetes or whatever it might be, you, Mr. Insurance Company, can't say, oh no, we don't want you. And community rating is that sort of everybody's like you're thrown in the pool with those 800,000 people. And you're all the health status of the group as a whole is what determines the insurance rate. There is some distinctions with respect to age, so that in Massachusetts we can charge a little bit more for older people can be charged a little bit more than younger people can. But is that basically right? Community rating?
Yeah,
and
it is, and I think
guaranteed issue.
I think what's important for viewers to realize is that there's a trade-off happening here with those sorts of regulations. The first one is everybody pays more as a result of them. In the past,
explain why, Josh.
Correct. So,
please.
from the standpoint of guarantee issue, the insurance company actually doesn't know your experience, doesn't know they can't ask you questions when you apply for insurance.
Right.
So in essence, they have to charge you as if, almost everybody, as if they were sick, because they don't know as a result. On the community rating piece, what we do effectively is say, we're going to squish the premiums to the middle, and we're going to charge everybody the same. So the end result, as you said, was for younger individuals, they actually, in reality, if you look at what their real experience is, they should pay less. So they're actually subsidizing older people who should be paying more. And again, the rationale typically is young individuals just starting in their career who are at the lowest amount of money they're going to make versus older individuals who are usually more established. But we have made the policy decision in this state and then with the ACA nationally to just push them in the middle. But as a result, you charge a lot more to everybody. So I just want to make that distinction. And you see nationally in the conversation some changes in the ACA, and Massachusetts has an even more restrictive or more narrow policy than what
in terms of the age band,
as far as how much you can charge. And just so viewers understand, even regardless of what happens in DC, if something ends up passing and becoming law, Massachusetts can decide to keep the regulations that it has.
Yes.
It doesn't necessarily get forced into changing those regulations. You always go more restrictive or higher, if you will, as a result.
I'm someone that's pushing 60, but I do think I have three 20-somethings, and I do, you look at some of these young people, Barbara, and they're battling student loans and just trying to get off their feet. I do think we've gone a little bit overboard on making them pay too much of mom and dad's costs. I think there's a better happy median ground that we should look at.
So let's what I want to talk about now are pre-existing. Now, something that Josh said in terms of insurance. Now, my idea of insurance is that not my idea. I mean, insurance is spreading risk over people. So, in terms of health insurance, I believe that the sort of the best recipe is to get the largest number of people you can with all kinds of health risks, all ages, young, old, sick, well. Put them in a pool, figure out what that rating is. And yes, there are going to be some cross subsidies, that healthier people are going to be providing some subsidies to older people. But if you don't do that, and I do have a question at the end of this, but if you don't do that, that when you end up doing is sort of segregating the unhealthy from the healthy. It's great for the healthy as long as they stay healthy in terms of insurance rates. Not so great if you're not so healthy. putting aside the age issue for a second. So I guess a question here, because it is coming up, and it's coming up, Massachusetts may have the option of doing this if some parts of the American Health Care Act do pass. A state can opt out of requiring that insurers charge everyone the same rate, but they would have to set up some kind of a high-risk pool or other mechanism to mitigate losses from that could occur to insurers because of the putting high-risk people in a particular pool. But so we can do different things here. But a fundamental question is this: before we even get there, should we charge folks with pre-existing conditions or certain conditions, whether it's asthma, diabetes, heart trouble, a million different things, more than we charge those without those conditions? So, just as a matter of policy.
So the short answer is yes, for those individuals that have not had coverage before. They waited. So the analogy is a tad crude, but let me give it to you anyways. In the homeowner insurance, we don't allow people to purchase homeowner insurance when their house is on fire. We want them to be able to purchase insurance ahead of time and pay the premiums so that when they do get sick, when they get cancer, which is what we would consider a pre-existing condition in most cases, they have been paying into the system and the insurance company actually has the finances to be able to pay for their care. And really, to give context for people, I think this has been one of the most disappointing parts of the media coverage of this whole debate about what's happening in Washington, is we're really only talking about people in the individual market. If you have insurance from a large company, Gillette, GE, one of those companies, if you have it from a small employer, there are federal laws that if you have coverage and you develop a pre-existing condition, such as cancer, you are not kicked off.
So we're talking only about individuals.
Correct. We are only talking about
less
individuals.
Less than that 800. But correct. Still, so it's a small number of people, but
a small number of people.
They can be hurt in a very large way if they're unable to get health insurance.
Correct. So we're talking under 10% nationally around the whole country in the individual market. So then the question becomes, when is it an issue that they could potentially be denied, or were they potentially denied before the ACA? It was only when they didn't carry insurance. It was not if they had insurance. And so the policy question that we have
But in order to get insurance, sometimes they had to pay a higher rate because you could, well, if we go back before get the laws in Massachusetts about guaranteed issue, you could be charged a higher rate the first time you come out of the box because you had cancer or something like that.
Correct. And so what's happening nationally, the way that this is being structured, just so people have a very clear sense, it does not get rid of this guarantee issue regulation that was on the books from Obamacare. It doesn't get rid of that. So the controversy has come that a state could apply for a waiver and say, for my individual market, I want to set the standard instead of the federal government. So we are talking about a slice of a slice of a slice of a slice here. Individual market in one state that applies for the waiver. Massachusetts probably will not, but another state may decide to do so. Only in the individual market, only for those who haven't had continuous coverage, and the state still sets the standards by which how these people are assisted or not.
So maybe let me rephrase my question a little bit, and John, jump in here too. I'm talking about someone with a pre-existing condition who is insured now, and what you're saying is that as long as they remain insured, the insurer cannot turn around Correct. And increase that insurance premium based on the fact that now I have cancer and I didn't when Correct. I first bought my policy. Query then, what happens to people who come into the market for the first time, for whatever reason? Mm-hmm. You might have been under your husband's insurance or wife's and they died, or you're divorced or whatever, or you're just coming out from under your parents' insurance and you have a pre-existing condition. Now you're a first-time buyer, and the reasons can be perfectly benign. Not waiting till you get sick to take advantage of the system. Sure. So what happens to you then?
So
I have a pre-existing condition. I've got cancer.
Yep. So the way that it's thought about, and at the federal bill that's being debated, is that you would have the potential of a 30% surcharge for 1 year. So you pay 30% more.
Because I have the misfortune to have cancer.
Correct. In that instance, and so that's a possibility, but there is a really important program that's baked into what came past the House, and it's actually modeled off of one in Maine. And just for explanation's sake, let's say John and I both apply for insurance at the same time. We would actually fill out a brief little questionnaire, and if I had cancer, I would actually get designated for the program, and then I would never know this, but I would get designated for a program, and the insurance company, in that case, I would pay the same. I get the same insurance product as John, and we would actually pay the same premium. Everything would be exactly the same, but the insurance company would know they get a little bit of assistance for my high cost. So there are mechanisms, there are ways to be able to help people with pre-existing conditions in this sort of situation, but it also can drive down premiums because the insurance companies know they have certainty on who the sick individuals are. So there's mechanisms that are possible. The rhetoric has been very heated on this, and I think unfortunately we've lost the actual discussion of how we drop premiums and help those with pre-existing conditions.
Just let me interject one word, and then we have to move on to Medicaid, or we're never going to get to it. But this is a controversial subject. I know I am familiar with the Maine program, which is one type of risk sharing, but there are others too. There are other kinds of high risk pools. In Maine, as you know, there's controversy about the outcomes there. Some people say that benefits were cut, including maternity leave. There was 30% co-insurance. It still costs money, and everybody was assessed $4 a head, I think, in order to pay for it. It's unclear whether that was enough money. But even under the American Health Care Act and its provision to permit these high-risk pools that may be different from the Maine high-risk pool, it still depends on federal money. I mean, it's all about money. Somebody's got to pay for those risks. And the individual is going to pay some, the insurer is going to pay some, the federal government is going to pay for them. If there's not enough money there, it's not going to work. And we have had a history in this country of high-risk pools. There were about 35 of them before the ACA came in, and they were not terribly successful. Everyone says it's all about the money. It's all about the money there. But I want to just jump into Medicaid, because this is such an important issue here, and we don't have a lot of time. It comprises what, 40% of the state budget?
40% of the state budget.
We have almost over 1 in 4 people here on Medicaid, and we did join the expansion under Obamacare. That brought in another 500,000 people on Medicaid, and then plus, in addition to people being subsidized. What are we going to do, period, about Medicaid? What kinds of solutions here? We solve this problem right now, John.
It's a big problem. I think we need to put some gates up. You know, it used to be under RomneyCare. If you were offered an employer health plan and turned it down, you were not eligible for these taxpayer subsidized plans. That went away with the ACA. That needs to go back up. We need to get a grip on some people that are gaming the system, both consumer-wise, that probably should not be in these categories, maybe should be in something in the middle, in the connector, a lot cheaper with some co-pays and
getting some subsidies,
and some subsidies,
but not total free health care under Medicaid.
Exactly.
Is what you're saying.
And also, frankly, we've got to get some of the providers under control as well. There are too many where the Medicaid dollars did not follow the patient. In a new world, the dollars have to follow the patient, and there were a lot of providers that pre-Obamacare, pre-RomneyCare were giving big pots of money, hundreds of millions of dollars per year, just because they had a lot of uninsured folks. Well, people are insured now. Those payments still exist. And a lot of them have a lot of empty beds and just never cut expenses. And we need to work on some of that on behalf of our taxpayers.
So it is a big problem. And if we lose, the governor is saying we could lose up to $2 billion a year, I think. If the American health care passes as it is now envisioned, because it cuts $880 billion off of Medicaid, we in the state would have some tough choices ahead of us. So I know we have I keep saying this, but I know we only have a couple minutes left. What about, you mentioned providers, and not just Medicaid providers. Let's just talk about providers. Hospitals, for example, who are big hospitals with the power to keep prices up. We have a real problem in Massachusetts we are so high priced in terms of healthcare. We have good quality, thank goodness. I think we can all agree on that generally. But even small providers, community hospitals, have good quality. Oh, yes. So high price is not necessarily a reflection of quality. What are we going to do about the high prices that? I wish I had $1 for every commission that has studied this issue and not come up with a solution.
We need to put the power back in the hands of the payers of the healthcare dollars, not the receivers. Right now, we're a little bit pregnant. We're not really a truly competitive marketplace on healthcare, nor are we government regulated. And who by default wins on that? The providers. The providers have all the power in the marketplace. And until we put the power back in the consumers to make the decisions themselves, we're not going to solve this problem.
Part of that could be transparency too. So you're not talking about insurance companies. when you said payers?
I'm
Or are
talking
you?
the consumer.
Consumers.
Primarily the consumer.
Josh, you
and
want to
I.
jump in
Yeah,
here?
and just very practically speaking, I mean, what's absolutely remarkable about this is that you could get the same procedure, let's say an MRI, for instance, and you'd see price variation 300% different just across the street in some
Right.
cases. And so I think John's point is, with individuals, paying deductibles in particular, we need to make sure that they have this information. Thankfully, technology is actually starting to allow tools to come onto the marketplace that allow you to see some of this. They're not widely utilized right now, and we do have a state law here in Massachusetts.
We do.
Where every insurer should
Yes, we do.
have a transparency tool. So for viewers, you should be able to call your insurance company or go on their website. They're a mixed track record for what insurance companies offer, but you're also able to call your provider. I think in the future here,
For
really,
and get price.
and get a price for how much will be paid for your procedure. In the future, if we're being realistic, you're going to pull out your smartphone and you're going to look at your
Right.
different options.
Right.
And some of those tools exist, and they're well worth looking into. And we think, I think in particular, that insurers need to do more to empower the payers, ultimately the patient,
the ultimate consumer.
the ultimate consumer, to be able
Right.
to have those tools in their toolbox.
Well, that's a great note to end on. We're not there yet, but keep hope alive and keep plugging away here. So let me thank both of you. John, thank you so much.
Pleasure.
And Josh,
Thank you, Barbara.
great. Thank you for coming over. Appreciate your being here today. This was terrific. And we'd also like to hear about you, our viewers, about the issues that you care about. So if there's a topic you want us to cover, drop us a line. Our address is baystateforum@cctvcambridge.org. And thank you very much for listening, and we'll see you next time on Bay State Forum.